Okay, so HIV progression can take years, like we've already said. Re-exposure, maybe how high risk somebody's behavior is, that all can affect the progression from HIV to AIDS. The ninth edition kind of went over this. I don't know if the 10th edition does, but there are new CDC guidelines that if there is a child maybe that lives with family members that have HIV, that they can start doing one-time screening for individuals. So that is kind of nice just to, maybe if maybe somebody's raised or things like that, they just want to kind of keep a closer eye on younger individuals. Lab testing. So we do watch the CDC, their white count, because their white count may look lower. We're having lower lymphocytes. And then our CD4 T cell count, we do monitor that. Okay. Viral load testing, I've already told you. How many copies do we see if they are at a high risk for transmission? 100,000. A lot of copies. This is our gold standard. To be honest, your book does not even talk about this. I do because I still see, I've kind of asked the right one to take it in class just to see if they've had these questions. And they still have these questions, but they're not in the book. So I don't know why they don't still go over this stuff. If they're going to, if it's still being tested. If they're going to still test on it. So your ELISA is your gold standard. It's the one, the kind of the initial testing. Okay? Kind of checks for the antibodies to the HIV. So we kind of look at that. How we confirm it is with a Western blot test. That is our test. We confirm it, and we can repeat it within 3 to 6 months if we don't really see, if it's indeterminate, so we can repeat that. But this is only to tell us if they have HIV. This does not tell us anything about AIDS. This is just to say HIV. Does it test for AIDS? No. HIV. Clinical manifestations. So this is things that we may see with AIDS. We go into a little bit more detail. I'm actually going to have you guys do a group project here in a little bit that you all get up and talk about each of these things. Because to me, I can stand up here and talk to you all, and it's not going to sink in. It's when you all do the work that it sinks in. But pneumocystic gyrivectin pneumonia is the most common infection with people that have AIDS. Okay, so they get a pneumonia, then they have HIV, then we start thinking, is it the one that could go along with AIDS? If we do not know what their CD4, if it's been a while since we checked their CD4 T cell count, and they come in with any of the AIDS defining characteristics, which there is a chart in your book, and it says key features for AIDS or AIDS defining key features or something like that, and it has all these lists and stuff. If you see any of those and we have no clue what that number tells us, then we can basically say that they fall in which stage? 3. Without even knowing their T cell count, we would say 3. Now, we can't say that as nurses, but the physician would come in and check them and say, hey, they have pneumocystic gyrivectin pneumonia. They're now at stage 3. TB is also a risk that we see. Oral candidiasis, what is that? Thrush. So a lot of patients may get the thrush. They may have the mucositis, painful mouth, just, doesn't feel very well. So what are some things that we can do for these patients?
Comfort.
What is it?
Comfort care.
Yeah, comfort care. Yeah, nice that. And we can do, think of the diet, things that you would do versus things that you wouldn't do. Wasting syndrome, do you know what that is? It is what it says. They basically waste away. Okay, so you guys will again go through some of these things, and then we'll go into more detail of these with your group project. Okay, the first thing we have to do, and we kind of went over this the first day that we were together, we have to notice. We have to notice everything before we can say that they're progressing into AIDS. So we have to be the ones that notice these changes. Again, we're checking their history, sexual practices, age, occupation. I mean, occupation's huge. People get stuck all the time. And even though there's a low percentage of people that actually get it from, transmitting from a stick, we still have to be cautious. Again, some other things that we'll include in your group project: increased risk for infection, and then psychosocial. Why is this even important?
People who get HIV a lot of times can withdraw, feel like they can't be around anyone, and kids, friends are going to hang out with them.
Right. I mean, what about family members? Can you assume in a hospital, you have a child, they're in the hospital, I'm calling, I want to know what's wrong with them. They tell the nurse, I don't really want her knowing, I love my mom, I just don't want her knowing anything. I even thought the other day, I thought, you know how we have those numbers that we have to give our patients. Hey, this is your security code to let somebody know these details. Wouldn't it be kind of neat if we had a patient in this circumstance that says, I don't care if you tell my mom stuff, I just don't want her knowing that part. So it would be kind of a security code. So we'd have two different codes. So you would give the mom this one instead of the one that you don't really care who knows that stuff. So then that way, because sometimes family kind of, I'm not going to say threatens their family members, but they're like, why don't you want me having a code? So, why don't you want me having it? I'm your mom. I was like, I'd probably be like that with my kids, like, well, you're not your mommy. But we have to really respect the patient and what they want. A lot of family members have, I'll be completely honest, with my family, I grew up in a very, church, Christian household. Some of our families don't even talk to us because, when I went to school and my mom, we had friends that maybe they didn't think we should. Okay, so when these circumstances would come up, I'm like, we may not agree with things, but we can still respect each other, right? Some people aren't like that though. So it's very sad, and you can't just think if my parents are very accepting, somebody else's may not be like that. So we got to be careful with what information we give out and what they're okay with. What are some things if they don't really have social support at home? What can we do?
We can find them
Counselors, the support. I mean, they have support groups, and that's a fantastic way so that they feel like they have an outlet, somebody to talk to. AIDS key features. Again, we are going to go over most of these. The reasons why this stuff is so important is, one, the symptoms that we are managing for those that have AIDS. It may be a fungal infection that causes diarrhea. So then you all, when you do your group project, you'll say, these are interventions we need to do, and they're in your book. I want you to utilize your book when you're finding these interventions to do with these patients, because that's going to be the management questions that you're going to be asked. What do you do in these circumstances? They have toxoplasmosis and encephalitis. What are you going to do about it? How are you going to monitor these patients? What are you going to do? And so forth. We'll go back to that when we do our group project. So treatment. It is individualized based, so we don't just give, it's not one, what is it, one shoe fits all. Is that how this one shoe fits all? We can't just give the same medication for each person. Most of the time with these medications, they no longer call this heart therapy. They call, I don't even know what they call it anymore, but they call it something different. But it's multiple medications given, combo retroviral medications. So they give it in a combination. Why do we give multiple medications at one time? So if it doesn't help one way, it'll help another way. And that's why we kind of combine treatment. It is long-term medication management. Can they take it one time and be done? How often do they need to take it? Every single day. So these are patients we may have, you have to come, you got to be, if they have phones, great. Some patients may not have phones, so calendars may be good. Pill organizer may be good for these patients. Anything that they're going to see. I always tell patients, especially if they have a pill organizer and they like to go out and have fun, great, fine. Make sure they have that with them in their purse or something. That way, if they're going to stay over somewhere, you never know when that's going to happen. So if you do, you have those, you take them when you usually take them, kind of like birth control. What happens, how do we monitor compliance with these medications? Yeah, so we're going to see, we're going to keep checking their CD4 T cell count and their viral load. Because if we see a decrease since last time, we see their viral load increase, then that may mean they're not very compliant. As opposed to somebody's levels are actually, they used to be 150, now they're 230. So is that better or worse? It's better. So then we're saying that they're being compliant with their medication. When I ask you questions on tests, I'm not going to say, is it, I'm not just going to go in here and say, this one. Okay, I'm not going to do that. I'm going to, if I say one of these, I'm going to put the group with it so that you know that's easier for y'all to study. I'm not going to try to trick anybody, anything like that. I did that on the chemo test. Same thing here. You're going to have your categories because all of those nursing implications, things that we do with the patient, those are the things that you're going to want to know. I do not do the combination, so don't worry about this one. Because you have to figure out where these go and stuff like that. So the rest of these, I will ask. So when you're studying these, so it blocks the CCR5. What's the CCR5? We went over it when we looked at the cell. What is it?
Is it the one they like the most?
Yeah, yes, it's a receptor. So we are blocking initiation from the start with this medication because we are blocking the fusion inhibitors. What's the fusion part?
Where?
Yeah, when it fuses to the cell, so we're not even allowing it. It may dock on that receptor, but it's not going to fuse. So that's where we block this one. Integrase inhibitors. What's that part? Yeah, that's protein. It's okay. But integrase. The way that you can remember this is integration. So it's integrating into the DNA. So the easiest way to remember that is that copy DNA after it transforms into DNA will then integrate to the cell's DNA. So integration. And then protease is where it starts clipping off those strands and it bubbles off. And then you have where it actually, you have two different ways where it actually blocks the transformation from RNA to DNA. But definitely know those because a lot of these medications, I'll tell you, stuff that falls out or stands out that you need to educate, especially patients with side effects, is numbness, neuropathy. Because a lot of these medications will cause that. So some patients may say, man, why am I so numb? And then it's because the medications are wrong. So we can educate patients on that. Let's see. Integrase inhibitors can cause rhabdomyolysis. So that is something that we want, that we want to educate how we want, and then any types of labs that we may need to monitor, those things are important. Flu-like symptoms, anything that we do with the immune system can cause flu-like symptoms. So I wouldn't really worry about something like that. But the ones that really stand out, like your laboratory checks, rhabdomyolysis, neuropathy, because that's common with these medications, educating stuff like that with these patients. How do you need to take certain medications? Obviously, it says there that you need to take 1 to 2 hours after antacids. Why? What is it? So if you don't really remember about antacids, a lot of those medications, you cannot take with those types of meds. So those are big ones to remember. And again, we already went over how we see if they're compliant with these medications is looking at the CD4 T cell count and the viral load. If they start beginning to have side effects, should they stop it right away? Be very cautious. Yeah. Be very cautious. Now, if it's an anaphylactic reaction, obviously we're not going to say keep it.
Yeah.
But if it's something like numbness, they need to talk to their doctor because the doctor may be able to do something else, but we don't want them off of these medications. Analysis, again, we will go over each of these when we are talking about all the different types of age-defining characteristics. I want to skip over to, because that all goes with your all's group work. So I want to go over to tuberculosis and finish off that, and then I'll let y'all work in your groups. So tuberculosis, is it a bacterial or viral? Bacterial. Transmitted how? Airborne. What do we need to do for airborne precautions? What is it?
You do the negative airflow.
Yeah. What else do we wear? Yeah, sorry, 95. So you definitely have to be, fitted and all that stuff. Initial infection, secondary infection, you don't really need to know. Initial infection is where they may be latent stage, active stage. What does latent mean? Do they have symptoms with latent? No, but they still receive treatment. You want to still treat them. And then they have active, which is they actually have symptoms. Secondary may be somebody that was, because this medication treatment is a very lengthy treatment process, these patients may actually may not be so compliant with this medication because it's every single day for like 26 weeks. So it's half a year that they have to be on this medicine. So if they start feeling better, what's going to happen?
Stop it.
They stop taking it. So then this nice infection lingers, and it may not be contagious at that point, but it can come back up again. Risk, we have homelessness, living in crowded conditions. So around here for pregnancy checks, so prenatal visits, we would do prenatal workup. We don't really do PPDs and all that fancy stuff like with our regular pregnancy patients. In Illinois, we did that every single pregnancy visit. So not every visit they came, but their first initial appointment, we always did that. Why? If I had a 98% population of Hispanic individuals, why would we do PPDs or the quantiferin test?
Live with their families.
Yes. Yeah, it's more of a risk for them. So that's why we did it. Substance abuse, malnutrition, things like that can affect these patients. So HIV patients, are they at risk for TB? Yes.
Yes.
So that's why we kind of combine these two because this is when TB really came about. Is when we started seeing this with patients. I added a lot of stuff on here, so I'm going to see what I added on here before I go over. Okay, so the BCG. Have you ever heard of the BCG vaccine? We don't have it here, but this is important to ask for people that come from different countries that TB is a high risk because they get this vaccine in those countries, and it reduces the risk of TB. But problem is if we don't know that they've had this vaccine and we do a PPD, do you know what it's going to do? It's going to light up that they have it, and then they're going to say, "Oh no, I had a vaccine," and we're like, "What vaccine?" So it's called the BCG vaccine. So we always question people that have moved from other countries, did you receive this vaccine? If they did, we go directly to the blood test. We bypass that PPD.
Is that a false positive?
What is it? Because it's not really, there's not a need for it.
Is it a false positive? It creates a false positive?
Mm-hmm. False positive. Now, I'm going to really rock your boat with a false. You just said false positive. I want to tell you what can cause a false negative now. If a patient has HIV, they have some symptoms that we think could kind of resemble TB or some type of some other type of respiratory infection. Okay, let's go ahead and we'll just say, oh, we're just going to go ahead and do a PPD on this patient. We do one, it's negative. Why may it be negative with an HIV patient?
Is it based on the meds they're taking?
Does it have anything to do with the fact that their cells are being changed and
They're
no longer?
immunosuppressed,
Yeah.
so they can't activate like they should. So they can actually have what's called, I did put it on here, hold on. Where is it? Oh, there it is, energy. So it is called energy. So it can create a false negative for an HIV patient. So in this case, if we know our patient has HIV, they come in, we kind of say, oh man, they have some bloody sputum, things like that. What should be our initial thing that we do for this patient? Isolation. We should isolate them right away. And then we would want to do the blood test. Like we're just gonna bypass that PPD. We don't want to do that. Physical assessment, so again, fatigue, lethargy, nausea, vomiting, anorexia, very prevalent with this. Fever, dull lungs, when they cough, they may have that bloody sputum, things like that. So that's what we see. And again, that's why there's all these different things that can affect the lungs for a person with HIV. So we have to test multiple things. But it's better, I'm always like safer. I'd rather be safer than sorry. Some people may live on the, what is it, the edge. I'm not like that. No. So isolation quiz. Imaging assessment. So when do we do chest x-rays? Yeah, so if the PPD is positive for a normal patient, when is the PPD positive, what size? For a normal population patient.
Greater than 1 centimeter or 5 centimeters?
Yeah, so it's 15 millimeters. So 15 millimeters is your normal. And then your patient population that are high risk of homelessness, those that maybe reside in crowded living situations, things like that, 5 would be their positive. Mm-hmm, 5. For normal, like they don't really have a lot of risk. So us that work in healthcare, sure we could be at risk for stuff, but we're still considered a normal population. So 15. When do we check it? Once they get it, when do we check it?
72 hours.
Yeah, 48 to 72 hours. And then you do your chest x-ray to determine active and all that good stuff. Priority problems. Must not have added a lot of stuff in there for that. So when do we educate patients when they're laying in bed with lung infections and all that stuff, like interventions we can do with them? Turn, cough, deep breathe. What about? I mean, I don't even know. Last few times I went, I don't even see the incentive barometers unless you have to do. Are they?
They're supposed to,
Do you?
yeah, because we have to go in there and charge it.
Okay, so they probably have them now. I know for a while they didn't even have them. But that's always good. That's also really good for your family members and some of the grandparents, whoever is really sedentary with COVID going around. I would get them stuff like that. Order it off Amazon because that can help and work their lungs. Let's see, anxiety, weight loss, fatigue. We've already hit those. So we want them to drink a lot, be able to eat. Those things make them comfortable. And then we get into your treatment, which is important. It is 26 weeks long. The initial 8 weeks, they take those 4 medications. And then for the remainder of their 26 weeks, they do the INH and the rifampin for 18 weeks. So these are things that you want to make sure that you would kind of review with the patients as far as this always freaks people out. I used to get phone calls all the time, even when people take Iridium, and they say, "Oh my gosh, my urine is orange and is my kidneys functioning? Yes, it's just a medication. So this is something that you would include. What else? What's some things that stands out in this? Maybe like rough handling. What's important? Yeah, we probably want to educate them that they need additional protection there. That's very, very important. Some of these other things, uric acid levels, but then what about this one? What do we see in this row? Yeah, your visual changes, optic neuritis. That would be something if they start noticing those changes, they need to alert a physician right away. So again, we educate on living situations. I never really did this. I feel like it's a little disrespectful if I tell people they should split their families up. But we can educate on why this happens, but not as far as telling them, y'all really should split your family members up, like not live together. Collaborate with other teams, and then let's see. This treatment may indicate a need for direct observational therapy. You know what that is? So if this patient, because this is a lengthy process and we really need to make sure that they take these medications because we don't want TB spreading all over, like maybe the community or whatever, we may need these patients to come in every single day and have somebody watch them take it. So we may have to set them up for something like this. This may be, maybe a home health case. If they can get it approved, something like that, somebody goes out there for 26 weeks and watches them take their medications. Dietitian to help with that weight loss. So we'll do the questions after, but I do want you all can take another break if you want, but you'll have some time to work on this group project. What I prefer you guys to do, if you want to do a little PowerPoint, that's fine, but if you would rather have you ever made pamphlets on Microsoft? You can change it, turn it into landscape, but you can put pictures on it, and then you can do some educational things around it. What I would like you to do is what the disease process is. Here, I can write it up here. Don't worry about that. I can write it. Does everybody know at Women's and Children's, 8:30 a.m., take your computer? Got it? I can write it up.
We will get out of Women's and Children's.
Okay. So, what it is, let's see. Maybe symptoms, signs or symptoms. Treatment, and then nursing intervention. Utilize your book, so your e-ball, get into your book. Chapter 17 is the HIV chapter, and through there you're going to see, I'll look up the page numbers, but that's where you're going to find this information. So, I'm not using my good computer paper, so I'll use my daughter's stuff. So, you guys all have 10th edition, right?
I have
You
nine.
have 9th? I don't want to do that one, because I wrote the 10th edition on there. Osmosis and encephalitis. So, you all can work as a group.
Prepared. Chapter, you said 19. Can I make that up?
Some of you may have 2.
Okay. Chapter 19. Toxoplasmosis. Toxoplasmosis.
And so, I've never did that. Toxoplasmosis. And so,
Who only has one? One thing. Here, you all.
Are you kidding me? I keep freaking dying.
I was gonna say, I don't wanna,
Not low hand.
yeah. I don't want extra. Not
So
today.
not like a headache. It just says that.
Whatever you think.
I've never done one. I mean, I can pull it up and try. I'm trying to find this thing. Whatever this thing is.
About you.
19 and then 9.
I was expecting a nice big headache.
Well,
You know, I have a 9th edition. Yeah, I bought my books off somebody.
in the 9th, it's 19 or 19, okay, so in the 10th edition itself.
Because I kept getting emails when we first started, like first semester. And about me getting my books because I hadn't gotten it because I bought them on somebody. And they were like,
Did she
they
say
called
that
me
it was
and
all
like,
in this chapter?
Yeah, it's just at 17 and 10
and they
position.
don't really have. Yeah, same.
Toxoplasmosis insect.
Yeah, Harley's got her book.
Yeah, I was gonna say I'm trying to search it in
Beautiful.
the
That
ebook
book's
and
too heavy.
I'm not finding it.
And mine's in 2 books.
Now, some of you